I'll talk on the situations which arise where we have a failed vertebroplasty. I think we all know vertebroplasty, and it's a rewarding procedure which gives immediate pain relief. It's commonly performed for osteoporotic vertebral fractures without neurological deficit. We all know this. Vertebroplasty is just putting the cement through the needle, and kyphoplasty is putting a balloon, inflating, making some room, and then injecting the cement. Uh, what all situations which may arise when we have a case of a failed vertebroplasty? One thing, maybe a short span of period, they have they are pain free, and then there is a recurrent back pain, which could be due to residual vacuum or poor cement augmentation in the first case. Uh, Immediate complication which can happen, which Satyan has showed now, cement leakage. Then infection is relatively rare, but it is a very serious complication. And long terms are usually the cement dislodgement, fragmentation, or late onset kyphosis instability. Uh, we have to analyze on a clinical assessment usually the back pain. Tolerable back pain, usually it is more like a mechanical, I would say, but something which is intractable back pain, patient is not moving at all, turning in the bed is also very difficult. I think we are suspecting infection or in such cases. Then obviously thumping tenderness, which gives some idea whether there is instability or there is still some the pain coming from the vertebral body. Obviously neurological things we need to look, radiculopathy, myelopathy, during our assessment. Uh, X-rays usually it gives us the information about the fracture pattern, whether it is a compression fracture or a burst fracture, end plates are intact or not, then whether adjacent vertebral fractures are there. We also can see the retropulsion in such cases. Most important, the sagittal alignment, we can know in the X-rays. CT scan is usually done in such cases to understand if there is a cement leakage. We need to understand uh, better understanding of the leakage. Uh, Obviously, if there is infection, we may come across bone lysis, destruction. Then recurrent back pain, we can study better way of intervertebral vacuum leg cleft if we are planning a revertebroplasty. MRI, I think we all know it gives a better impression about the spinal cord, the nerves, and again the cement leakage. If there is any spinal cord edema is there, any abscess formations. Blood work is essential. Whenever the failed vertebroplasty cases, I think it's very important to have a complete blood work. We should rule out the infections, associated medical comorbidity. We should have a complete idea. If we are planning any refixation, I think we should know what they are dealing with. uh, then obviously DEXA scan helps us to understand the bone mineral density. PET scan also, sometime it gives an idea about the METs and what kind of cancer is that. Uh, I talked about this residual vacuum. If there is no symptoms, I think nothing has to be done. We just observe. However, if there is a recurrent back pain, it is becoming severe and relatively the sagittal alignment is okay, nothing, no neurological problems, I think we can definitely consider a revertebroplasty from the opposite pedicle. In case primarily if it is done from the both pedicle, then there is something parapedicle also we can try. Infection, it is relatively rare, and there is two scenarios. One is a post-operative, immediate post-operative infection. I think this is a very serious complication and it needs extensive anterior posterior surgery. Primary misdiagnosis, sometimes, if we are not done enough blood work, and primarily it could be a tuberculosis and we thought that it is just osteoporotic fracture and we put the cement. That is also some serious situation where, maybe after 2 or 3 months we come to know that this is not something osteoporotic and this is turned out to be a serious infection. Cement leakage, again, usually we come to know on the table only. Obviously, we are usually doing it under local anesthesia, and if there is no neurological deficit, no radiculopathies, I think we can still observe this patient. And obviously if there is neurodeficit, we have to do urgent laminectomy. Also when there is an anterior column is already broken and now we are removing the posterior structures also, so we have to fix it. Usually for this cement, we have to go anterior and we have to remove the cement completely because it become very difficult to remove the cement from the posterior. So I'll come to this particular case, which is this lady, which is around 65-year-old. She is very obese, like 4 feet and 90 kg weight. She had a fracture of L2 in 2014. That time the primary surgeon has treated with the vertebro and the pedicle screw fixation. She was all right for 4 months. However, then she started having more back pain, and then she started having heaviness in the thighs. In 6 months, she has become wheelchair bound. Currently, when she come to me, she had a severe back pain, pain in both thighs, numbness, and she was not able to walk at all. So this was the X-rays. I don't have the primary X-ray. This was the X-ray when she had come to me. So obviously there was a failure of the fixation, and I think there was a retropulsion also of the bony fragment. This is the MRI where it is definitely showing there is a retropulsion, and both L2 nerve roots were quite tight. There was severe pressure. So what would be the plan? Dr. Vishal, would you suggest something for this? Okay, I'll just go ahead. Will not discuss it. So I did from posterior, I removed the previous fixation. I go to about 2 below. I did a complete decompression. I struggled. I tried to remove that segment from the back only, but I was not able to remove it. And then I go from the front. I removed that cement and I put a expandable cage. So I think this was the case which I wanted to present. Obviously, just vertebroplasty is not an option to every osteoporotic fracture. Burst fractures, usually if end plates are not intact, I think it's always advisable if you're doing any cement injection, then adequate fixation has to be done. Never overload the vertebral body with the cement if we are doing just vertebro or kypho. And usually 2-3 ml in dorsal, 3-4 ml in lumbar spine is more than sufficient to reduce the pain. This is just a summary, failed vertebroplasty. So if in case of residual vacuum, I think you can either go conservative or repeated vertebroplasty. In case of cement leakage, I think posterior decompression and adequate fixation is necessary. You have to grow in the front to remove the bone cement. Infection definitely need extensive debridement, anterior and posterior. Again, late onset cement dislodgement, fragmentation, always anterior and posterior surgery is recommended. Obviously, medical management and post-operative protocol is very important in these patients. So, percutaneous vertebroplasty is a safe, effective, but not risk-free. Careful pre-operative diagnostic workup is very necessary. Performance of vertebroplasty requires some technical learning and experience, and once the catastrophic complication takes place, I think acute or delayed, the spine surgeon should be familiar with the varied approaches and techniques for the revision surgery. Thank you.